I've been really looking forward to this occasion. You get lots of speaker invites when you do my sort of role, but I've really been looking forward to helping kick off the 25th anniversary celebrations in the right way. So the press is on me to get the next 20 minutes right. And all credit to the college as well for choosing to start off starting off a series of talks with one about patient and public involvement. Because I know there will be many patients perhaps in the audience and carers and members of the public who will also be watching it on YouTube in the future who I think raise a big cheer for that fact and as a sign that the college takes patient and public involvement seriously. So I actually wanted to begin my talk with a couple of reflections about the big picture. The first reflection is clearly the relationship between science broadly and the general public is a matter of ongoing debate, and often that debate is perhaps clouded in a notion of perhaps public understanding not being very good. We worry about that. We're somewhat neurotic about this. You can see that playing out in lots of specific debates about patient data or different aspects of science. But I think it's worth reminding ourselves that with regard to medical research in particular, we do have a very good relationship with the public, and I think one that we need to celebrate and recognise more. And that manifests itself in a number of very specific ways. So that manifests itself in the way that we have one of the biggest medical research charity sectors across the world, funding over £1 billion of research in this country and increasingly abroad, and that's over a third of all public funding going into research. We have quite a long history of the public tending to support cutting-edge research. And that's not to say that's without debate, but if you look at votes in Parliament, for instance, there's been consistent high levels of support for things like stem cell research, hybrid embryo research, and for scientists being given license to push the boundaries around medical research. We also see that in the altruism that leads people to participate in clinical trials. So just through the NIHR and the clinical trials we run, we've had 3 to 4 million people participate in trials over the last 10 years. And if you talk to people who've done that, they want obviously to potentially benefit from new treatments, but they also want to help other people through their participation. So there's a strong culture of altruism in our society that I think is a driver for this relationship and something we should recognise. And lastly, there is a real passion and commitment, I think, to be part of it, to be part of the decisions that are made about science and are made about medical research in particular, and perhaps a tradition of volunteerism which plays out in medical research as a sort of form of civic duty. And it's that bit of this bigger picture, I think, that often people think about when we're talking about patient and public involvement. But this, I think, is a cornerstone of our health research system in the United Kingdom, and something we may want to reflect more on in the future as we try and plan our way through the post-Brexit age, that we do have a supportive culture that's going to help us. The second reflection is about the history of patient and public involvement itself. And I think it's worth reminding ourselves of what the story is here. And generally, in brief, the story is about challenging the notion of the patient, the individual person who takes part in research, being a disempowered subject of that study or the work of the scientists, and actually beginning to see them more as the partner in that process. So someone who's actually helping to make decisions with clinicians, health professionals and researchers about not what just research is funded, but how it's done and how it's disseminated to improve the knowledge of our health system and broader society. So it's worth bearing in mind that story, because that I think will tell you a lot about the passion and the commitment that people bring to the table when they are patients, when they are carers, and they want to be part of what you're doing perhaps in this audience. And we have a lot, I think, to thank quite highly mobilised populations of patients like mental health service users, HIV, for that drive in the 70s and 80s that really, I think, caused the rise of advocacy around research. So the story of public involvement, if you go back 2-3 decades, is that change of philosophy from being seen as a subject to being seen as a partner. We are by no means at the end of that story, and as many people will tell you who've experienced it, but it's important, I think, that we keep it in mind. I'm very proud of the fact that the UK is really at the leading edge of public involvement in health research, and we have been since the very beginning when we started off with Involve in 1996. We at NIHR, when we were created in 2006, and we took Involve, which is the organisation that I chair and which is the National Advisory Group for Public Involvement, when we took it under our wing, we said at the very beginning that this would be a binding principle behind the way that we ran our business. And you have to remember that NIHR is the biggest government funder of medical research in the country. And from that day, we've set a clear expectation with researchers that we expect them to come to us when they want to have a proposal funded or a piece of research infrastructure, a new lab or whatever funded. They have to come to us with evidence that they've involved the patient, involved patients and the public in that deliberation about how they got there, but also a plan for how they do it going forward. We've done that through sustainable funding, so Involve is now being funded for 10, 11 years and will be funded for a further 5 years. So we're the only country in the world that's actually funded public involvement to this extent and for such a long period of time. And again, I think that's all credit to our commitment as a nation to wanting to see this part of how we do research. And there you can see some of the people who attend our Involve meetings, and we hold a conference every 2 years which brings together patients, carers, researchers, clinicians who are pursuing public involvement activities up and down the country and increasingly across the world, but particularly US, Canada, Northern Scandinavian countries and Australia. We have rallied, I think, as a movement, if you like, behind this definition of public involvement. I think it's probably a feature of being part of the health system and the health service that public involvement, like many others, has become weighed down somewhat with jargon and terminology, and that can be difficult for people to find their way through. But very early on in Involve and the NIHR, we took the decision to rally behind this quite broad definition around what we mean by public involvement. Broad in the sense that we include within that definition of public, service users, carers, patients, members of the general public, and also broad in talking about partnership and collaboration very, very strongly. It has served us well. We see it very much as a call to arms, a call to people to coming together, rather than some of the other terms which are quite divisive or can be quite divisive in how people interpret them. So that's really the route that we followed, and that's the philosophy, I think, if you like, the philosophy we've tried to influence others to follow when they work with us in terms of their research funding or how they apply research. So what are some of the benefits? What are some of the gains that we are seeing coming through because of the way that we've involved the patients and the public in our work? Well, I think the first is that we feel as though the work that we are funding is of greater relevance to the needs and priorities of patients out there. So you will know that through your own priority setting partnership in perioperative medicine and anaesthesia, that bringing health professionals, carers and patients together can be a very, very effective way to come up with a top 10 list of those research areas that needed to be investigated and funded. And this is a methodology that we house within NIHR, which we promote, which we encourage charities to also fund. As you can see there from the figures, we've done 31 of these. We have another over 20 on the way. They cover all parts of the body, as you can see, apart from the feet. I don't know what's wrong with the feet, but we haven't quite reached those yet. And so what you end up with is a list of these are the things that matter to patients and health professionals when it comes to research. It's not about putting things to a democratic vote, absolutely not. It's about bringing about clarity about what that agenda looks like and then being able to set that alongside the scientific agenda, the scientific priorities, and hopefully emerging with a much more balanced portfolio as a funder and as someone who's trying to promote and drive the health research system in the right way. The challenge for this, of course, is that you have a list of priorities and it's getting those funded. And I think there is a credibility issue that if we're going to do this work, we have to follow it through. It's no good having a series of, and a growing series of lists that we have from different condition areas or covering different parts of the body, but actually no commitment to fund those through. And I think that's going to be the next challenge behind priority setting partnerships. The next benefit that we are, I think, seeing, and what we can point to some evidence around, is just generally improving research design. So this is a schematic of a research cycle, what happens when you are doing research, and these are some of the examples of public involvement typically that we are seeing in different parts of that cycle. What's interesting to me over the last 10 years is that people, patients and carers, members of the public, are becoming more part of the research team itself. So it's not unusual now for me to see a research application which includes patients and carers as co-applicants, for instance, and who, when they come to be interviewed about the potential of their work going forward, are part of the panel that's being interviewed and cross-examined by us as the funder. So that's quite an interesting change, an interesting reflection in it, and it throws up all sorts of challenges. I'm actually involved in a study which is paused until the new year at the moment, which is looking at whether there's particular interventions, public involvement interventions that we can do in surgical trials which would boost recruitment and retention. And it's quite interesting in the first phase of this study that people, yes, they said public involvement was the morally right thing to do, but two, they said they did it because they felt it led to better designed research. And third, it was because the funder asked them to do that. So it's an interesting mix of incentives and motivations and drivers behind that. The other interesting thing about this drive to involve public involvement as part of research design is not just this study, but others have borne out the fact that the earlier you start this in the process, the more impact it will have. So many, I think, research teams are now sitting down with patients and carers and thinking about what that question looks like. What should that research question look like? Thinking about, okay, if we are going to run this trial, practically speaking, what can a patient manage to do and encompass as part of their life, either coping with that condition, but also coping with that condition and their family life and their work life. And it's very interesting when you talk to patients about this, those that say they've had the most positive experience about this are those that have been involved from the very beginning of a research project rather than invited midway through the course. We're also, I think, as a funder, particularly around clinical trials, seeing increasing research efficiency because of the way we are involving people. So in the olden days, one of the arguments often put up against doing public involvement was it's going to be another bit of regulation, it's going to be more burden, it's going to slow us down, it's going to absorb a lot of time and energy, and actually it's going to stop us from getting a clinical trial up and running as quickly as we might do. Well, nothing could be further from the truth. We've done 2 or 3 studies, pieces of work across the clinical research networks that NIHR runs now, which actually demonstrate that these trials get up more quickly when they've had public involvement as part of them. This is the first study that was done, 2013, in mental health, looked at all 345 studies that they'd done on a portfolio. They looked at the association between public involvement and studies getting up and running, and they found that those had what they called mutuality between patients, public and the research team, were 4 times more likely to hit their performance targets than those didn't. The other evidence is perhaps not as compelling, but it does show that there's an impact of public involvement on that efficiency. In this day and age, in an age of austerity, this is really quite important evidence to put behind public involvement. The other areas in terms of proving access to research. So a big issue for us as NIHR, as I'm sure it is, and it sort of plays out in terms of recruitment and retention to trials, is the lack of visibility of research when people use the health service. So it's quite interesting if you go to, I'm making quite a big generalization here, but if you go to Canada or America, often the hospitals there will advertise on their sleeve the fact that they do research. It will be a real badge of honor to them. In this country, it's less often the case that if you walk into your hospital, research will be very visible from the moment that you walk through into reception. And as part of our mission as NIHR is to increase that visibility, number one, and number two, to ensure that patients who use the health service and their carers and others are aware of the fact that there possibly is an opportunity to join a clinical trial or study that might benefit them. We see that as an important part of the treatment options that they might follow with their condition, whether it be cancer or stroke or whatever. So we've done a series of things as NIHR, but working in collaboration with a lot of other people. Our OK to Ask campaign is a campaign we run to coincide with International Clinical Trials Day every year and runs across the health service. And we've also started to develop online portals by which people can find out about open and recruiting clinical trials more easily. This is the UK Clinical Trials Gateway. I did a search yesterday when I was thinking about my talk on anaesthesia, and you can see these are the trials that are listed. It's an imperfect mechanism at the moment. There's a lot of work to be done on the data quality, but in a not too short long time, you will also be able to, well, you can register now as a volunteer to participate in future research. But in a few months' time, you'll also be able to register as a researcher, and by registering, have access to that pool of people who are, say, they put their hand up and said they want to be part of a research project. So a little bit like a matchmaking device. Making that task, making that route into research easier and quicker from both the researcher perspective, but also the patient perspective. I think we're also asking better questions about the research experience. So once upon a time, and we still do a little bit, particularly when we're trying to make a political argument, people have tended to go out there and do those surveys which ask patients, well, you know, if you had the opportunity to go into a life-saving clinical trial, would you do that? Well, of course, you know, 99.9% people are going to say that if you frame the question in such a loaded way. It doesn't really help us think about their care pathway and think about the decisions and the enablers, perhaps, or the barriers to making that final decision to come into research. And so we're doing a lot more now across our clinical research networks to sit down with patients and to understand what would make the difference to you. And a lot of this is common sense. It's the information, the fact that information is there that they can read. It's in different formats. It's the fact that the consent process is fairly straightforward. It's the relationship that they might build up with the clinical team or the people who are behind the research. Those are really important things for us to think about as a community in order to get that offer, horrible word, but it's quite an important one, offer to the patient right about what that research could mean to them and why joining could be beneficial. As a result, I think, of our work, what we feel as NIHR, and I think we feel as though it's a really unique part of the way we do things, is we've built a community that has a growing voice, not just in the NIHR's work, but across the overall research system. So we have a hardcore of people who are reviewing over 1,000 applications every year. Every application we get is reviewed on paper and at panel stage by lay reviewers. We have the people who participate for us. So this is a growing community which we're looking for more and more ways to work with and to involve them in the decisions we take. And you are doing the same. You have here at the college your lay panel, and it's been, I think, very interesting and impressive to see that grow. And in fact, I met one of the members of the, I think, lay committee upstairs who's going to a meeting in this building a bit later about clinical commissioning. And you are, through that, changing your own culture to be more embracing of the patient and more embracing of their agenda. And we have to do more of this. We have to do more about including patients as part of our governance. And that's certainly something that we're looking at the National Institute for Health Research. So a few final thoughts before I conclude. So I believe in a world of research which is going to work better because we have a strong partnership with patients, carers and the public. And I hope I've given you some evidence of the benefits of that over the last 10, 20 years. But I wanted to leave you with a challenge, and I wanted to leave you also with, I think, one of the most exciting areas where this could begin to play out. So the challenge, I think, is reaching out to diverse communities. We have an ever more diverse population out there, which we need to include and to involve in our work for it to be more reflective of their priorities and needs. So ethnic minorities, yes, of course, but I'm also thinking in terms of age groups. We have a fantastic reputation across the world for the way that we've involved young people in research. We have young people sitting down with researchers, writing patient information leaflets, working out how the design of a study should work. We need to do more of that, and that's a very interesting aspect of public involvement to our industry colleagues, and we continue to do more and more work with them. So that's a real challenge. How do we reach out to diverse communities? The really exciting bit for me is how we reach to this vision of co-production. You'll see that word bandied around a lot, and it's, I suppose it's the new word on the block. And you can see that a lot coming from the NHS as well. For me, co-production is about equity in a room. It's about having equal partnership to devise solutions to common problems. Just a few miles from here, one example of that co-production is My Medication Passport, done by the North West London Clark, Collaboration for Leadership in Applied Health Research and Care. It was thought up by patients. It's basically a passport in which you can record every change in your treatment and every change in your medicine as a patient, which you can use with your health professionals so that when you cross professional boundaries, when you cross organisational boundaries, the risk of mistakes in your medication, in your adherence or whatever can be minimised. 100,000 of these have already been downloaded from their website, and it's increasingly attractive to people in the health service, but also to other systems across the world. The other one is Cloudy with a Chance of Pain, which is really great. So this is for people with arthritis and experiencing pain symptoms as a result of that arthritis. For a long time, it's been a reported patient symptom that there's an association between those pain symptoms and weather. And for a long time, they felt that that was a dismissed report from them, that people would not listen to that as much as they should have. But a team in Manchester University, research team led by Professor Will Dixon, devised with patients this app called Cloudy with a Chance of Pain. So it's an app, it's also on the website. What you do as a patient, you can record your pain symptoms at any point in the day or night. At the same time as you reporting that, it uses the GPS technology in your phone to track the weather at that place. And hopefully to generate data to show that association or not. And they've released some early results last month at the British Science Festival to show that there is a very interesting association that seems to be emerging between, for instance, rain and damp and arthritic pain for people. Really interesting. It enables people to begin to think about their day as someone with arthritis. Enables people to think about how to advise them better. A very co-produced solution with lots of potential to help people cope with chronic illness very much better than they can do currently. So I hope I've given you some sense of the past, I hope I've given you some sense of the present benefits, and I hope I've given you some sense of what the future may bring to us. Thank you very much indeed.